The
Now
meeting number is today what?
we are live. We are live.
We are live. So, hello everybody. Greetings from Confederation of Medical Association of Asia and Oceania. I'm Dr. K. Agarwal, the president of CMAAO. I welcome you all in this meeting, which is going to be our 28th meeting, weekly meeting. And today we have two subjects to discuss. And one subject we are discussing is CMAAO update. World Medical Association meeting is coming. And in the World Medical Association, our presence we will discuss. But before that, because we will have another 10 minutes for people to join, I want to give a 10 minutes presentation before everybody comes to get it passed by the CMAAO. And I would like Dr. Jamal Luddin Chaudhary and Dr. Chong, when he joins from Singapore, our chair, to jointly chair this meeting. And in the interest of time, I want to give a small presentation. Every week, we try to bring out a consensus statement on behalf of various countries. Today, I am presenting for 10 minutes an important subject, and that is the choice of anti-inflammatory drugs in COVID-19. And we welcome Dr. Tinio from Philippine Medical Association. She has joined us for the first time. So, Chair, first welcome our new entrant, Dr. Jamaluddin Chaudhary. Dr. Chaudhary.
Yeah. Yes. Let me see who's joined actually. So it's who is from Philippines?
Dr. Christine Tinayo.
Christine Tinayo.
Yes.
Yes,
Hi.
Oh,
day.
hello. Hello.
Hello.
Dr.
Good morning. Good
Jamaluddin
morning.
is chairing
Yeah.
this session.
Yeah.
So
Yeah. So
I'm going to give it a 10 to 15 minutes presentation. By the time others will come, and then we will start
Yeah.
our meeting. So I quickly go
Yeah.
through an important aspect of COVID and anti-inflammatory drugs.
Yeah. Please go on.
This is, everybody knows about the virus, how it looks like. We know the spike and we know the E protein. And E protein is common to all viruses. All coronavirus has the same E protein, but their spike protein differs. If you see on the top, this is the top of the virus. This is the bottom of the virus. This is the S protein, which has two components, S1 and S2. This is the RBM component, and this is the membrane component, which is how it looks like. If you can see here, this is the S1 component, and this is the S2 component of the virus. This is the receptor binding domain, and this is the membrane binding domain. It is the receptor binding domain by which the virus attaches. Viral entry into the cell is by the cleavage of S1, S2. And inside the cell, virus releases the main negative from which the files have to be made, hijacks the whole virus, which starts making new viruses. This is how the virus entered, captures the ribosomes and makes ribosomes at its own. This is the infection, which can be asymptomatic, mild, moderate, and severe. And these are the various types of immunities, which are, we have when the virus enters my body, various types of cytokines, interferon alpha, TNF, that takes care of the virus, specifically interferon 1A. And sometimes if the virus is not killed by them, it is taken care of by the natural killer cells. And if interferon 1 is not formed, then you end up into a cytokine crisis. And these are the acquired antibodies by the B cells, where we form IgG, IgM, IgE. And these IgM antibodies can be receptor binding antibodies, or it can be protein antibodies. Now, this is what we call them as, there are three types of cytokines: pro-inflammatory, inflammatory, and anti-inflammatory. Today, one lesson we are learning is, so whenever you evaluate yourself, you ask yourself, am I in a pro-inflammatory lifestyle? If your lifestyle is pro-inflammatory, any virus will make it inflammatory. And if you don't have anti-inflammatory compounds, you end up into inflammatory. Now, these are the different types of cytokines which are present, which we will use when we come. Now, these are the different types of defense mechanisms which we use. And this is NLRP3 inflammasome. I'm not going into the details of that because these are well known to everybody. But this slide, I want you to go through slightly in detail. And that slide is when interferon 1 is not formed, then macrophages will form NLRP. They will produce IL-18, which causes damage. IL-1 beta, which causes hyaluronidase formation. It causes increase in fibrinogen. And then Th117 response produces interleukin 6, which produces fibrinogen and CRP. TNF alpha by phospholipase A produces inflammation. IL-8 will increase your neutrophilic migration, and which causes inflammation in the body. So if you really want to act anywhere in the body, then we have to act at prostaglandin level, TNF alpha level, IL-6 level, and COVID-19 level. And if you see prostaglandin level, we have various drugs, we can block it. Now, these are the various areas where you can act, and block the virus and virus activation. Now, these are the treatment approaches. Either you block the TNF, or you block the interleukins, or you increase the interferon, or you act at the level of colony stimulating factor. So these are the various targets which can affect the virus. You can block one cytokine, you can block two cytokines, you can block multiple cytokines, you can block lymphocytic trafficking inhibitor, you can block lymphocyte trafficking and lymphocytic retention inhibitor, lymphocytes aggression from lymph nodes. You can block lymphocyte coming out of the lymph nodes. You can increase anti-inflammatory good cytokines, and you can start some oral therapies. Now, these are various areas where you can block. These are the various areas where you can block. These are the areas we can block. So I'm coming back to an important aspect, and that important aspect is we are seeing a response that patients are not responding to paracetamol. Then we went to the immunologist.
आप म्यूट हो गए हो.
So when we went to the immunologist, why people are not responding to paracetamol, they said this is inflammatory condition. And in an inflammatory condition, you need to give them a medicine which stops cytokines. This fever is not only thermostat dysregulation, this is a cytokine fever. So in a cytokine fever, paracetamol may not respond. So we started working on three drugs. And so we started working on three drugs: mefenamic acid, indomethacin, and naproxen, to find out whether where are they targeting. So we found that we need a drug which blocks the virus cell entry, and we need a drug which can modulate the immune defense. So therefore, we need a drug. Now the drugs here are indomethacin, naproxen, and mefenamic acid. Somehow we were finding mefenamic acid as a better drug than naproxen. So we again went to the immunologist. They said that indomethacin, we are no more giving indomethacin nowadays. We are choosing between mefenamic acid and naproxen. Then we started going further in these particular conditions in terms of NSAIDs, mefenamic acid, paracetamol, indomethacin, and naproxen. And we started modulating it in terms of NLRP3, inflammasome, and prostaglandins. And we found this particular thing. And that was that when it comes to hydroxychloroquine, it does not act on NLRP3. Azithromycin does not work on IL-18 and NLRP3. Doxycycline does not work that much on IL-1 beta, IL-18 and NLRP3. Ivermectin only inhibits the viral replication. Mefenamic acts at both the places. Then we went through the literature here. Paracetamol increases IL-1 beta. On the contrary, we want it to reduce it. It has a neutral action for interleukin 6. It reduces TNF alpha, therefore it reduces fever because of TNF alpha. It does not reduce the cytokine fever. So the idea of bringing it to the CMAAO forum here was, before we take up our regular CMAAO meeting, is do we have an experience of other countries where we find as a anti-fever drug and anti-inflammatory action, the mefenamic acid is better than paracetamol? Dr. Jamal Chaudhary.
Yes, thank you. Actually, it's true that mefenamic acid is working better actually in fever. So it also experienced here in Bangladesh regarding this.
Bangladesh, we have the same experience. Anybody else? Pakistan, what are the results?
Dr. Kaisir Sajjad.
Dr. Kasir Sajjad. Yes, kindly go ahead, Jamal, and ask everybody.
Very much, Mr. President. Yes, it's true. In few cases, this mefenamic acid is worked, but mostly we use and we get result from the simple paracetamol 2 tablets. So we are using here simply as a paracetamol mostly in most of the cases.
So in a post-COVID phenomena, when we need an anti-inflammatory, so what we have seen is paracetamol is reducing fever, but it is not bringing the CRP down. And mefenamic acid, we are finding it is anti-fever as well as it is bringing the inflammation and it is bringing the CRP down. And nowadays, we are more worried about the CRP as a long COVID and a post-COVID phenomena. So paracetamol is a very good anti-fever medicine. But when it comes to, because here we need also a anti-fever with an anti-inflammatory action. And therefore, this is what we are saying is, if the CRP is persistently on the higher side, then mefenamic acid, naproxen, linezolid, indomethacin, these are choices with us. And based on our immunological consultations, we went and analyzed these 4 drugs and tried to see which drugs are sounding better. So we found by the literature that mefenamic acid, number 1, which can be given for 3 months. Linezolid cannot, if it is given only for the first 2 weeks, because it rapidly reduces the fever. Then comes this indomethacin, then comes this naproxen, and then paracetamol does not have an anti-inflammatory action so strong.
What about the ibuprofen? Ibuprofen also.
Yeah.
Ibuprofen, we did not went through the ibuprofen because in the first few days there was a big controversy on ibuprofen because a group said take it, a group said don't take it. So we did not analyze the data on ibuprofen because this is any drug where initially for the first 2 months there was big controversy on ibuprofen.
Actually, they also said, Dr. Agarwal, that basically it may be associated with adverse events, particularly with people who are suffering from acute respiratory infections. So that's where they are not using non-steroidal anti-inflammatory drugs. And also there's a question mark on COX inhibitors as well. So I wanted
Agreed,
to...
but at this moment, we are looking for a drug which reduces fever and inflammation both as a steroid sparing.
Yeah.
Mr. President,
Yes.
President, can I just would like to know that what about the diclofenac, sodium and potassium? Do you have any experience with these drugs?
That's not a very good antipyretic. That's a purely anti-inflammatory.
Inflammatory.
So we are looking for a drug which has both the actions. So therefore, we did not do the literature survey for diclofenic acid because that's a very good painkiller. But we are talking about anti-inflammatory action. So we did a literature survey of people where we wanted to know a literature survey of anti-inflammatory antipyretic. The idea, we took it from immunoinflammatory arthritis, specifically inflammatory spinal polyarthritis, inflammatory spinal, seronegative inflammatory spinal arthritis. Because in this condition, we are not getting, we are only getting joint pain in the back. We are not getting peripheral arterial arthritis in this condition. So we started matching our findings with inflammatory spinal arthritis, and we started finding a lot of similarities in that. And then we started literature surveying where anti-inflammatory action is there. Then we identified all the drugs which causes anti-inflammatory. Then we started selecting anti-inflammatory and antipyretic. Then we started selecting antipyretic which crosses blood-brain barrier and which crosses blood-brain barrier and should be able to readjust my thermodysregulatory system. So we shortened our list to mefenamic acid, to naproxen, indomethacin, and nimesulide. These were the 4 drugs which were shortlisted. And these 4 drugs, therefore I'm asking is because our clinical observation is more for mefenamic acid. So therefore we were asking other countries, what are your observations with that? The immunologist says all 4 drugs should work, whether it is mefenamic acid, but nimesulide cannot be given for more than 2 weeks. And we are here having a long COVID where you may require a steroid sparing anti-inflammatory drug. So if you need to give a steroid sparing anti-inflammatory drugs, either you give them steroid, we can't give the monoclonal antibodies as yet because they are not recommending. So if we have to choose, then we are left with mefenamic acid, naproxen, and indomethacin. Indomethacin, we give it more when we have a spinal problem. Specifically, indomethacin, we give it in post-chikungunya, where we have been giving it. So we are coming back to 2 drugs, mefenamic acid and naproxen. Naproxen has been given in HLA-B27 arthropathy and closing spondylitis for a year as the first year treatment. And the mefenamic acid is also being given there. But here we are finding, our observation is, it was the people who started saying, Daksa, what are you giving that we are responding better to mefenamic acid? Then we started looking at it. So that we thought, started sharing it with the people that maybe, and then we started looking at the literature. Pooja is our pharmacological expert. Dr. Ketan Mehta is the one who has used a lot of this data. They are, we have called them as to discuss this particular issue. And so we started looking at that, is it our observation or is it backed by the literature? So can we have Dr. Ketan Mehta's comments?
Yeah. Good morning, sir. Good morning, everybody. At the onset, let me say whatever Dr. K.K. Agrawal is present, which is a fantastic presentation and given an overview. Now, we as a clinician must understand 2 aspects. That in the first week of the COVID infection, we need to see that it is the presentation or manifestation which is happening because whatever the virus is doing to the body. And in the second week, it is what the body is doing to the entered virus in the body. So during first week, when it's a virus replication phase, we need to be careful about the drugs which we choose, because the drugs which we choose should not help the virus replication. For example, steroids. So steroids should be totally cannot be given. Now, as sir has already rightly said, whenever we are talking at NLRP3, inflazomes, or whether we talk of antiviral properties, that combination when we have with mefenamic acid, which can be safely be used in the right from the first week of infection, where people have a tendency to use steroids just to bring down the fever, but which can be detrimental. So you have the effect of antiviral, you have an effect of antipyretic, you have an effect of anti-inflammatory. Now, all 3 effects which you get, that is only with mefenamic acid, which we have seen. And we have been treating left, right, and center. In fact, I would say morning in the round, I just started with 5 new patients with mefenamic acid. And those who were started yesterday and all, they are showing excellent response in terms of the pyrexia. So I would strongly recommend to go for mefenamic.
So what I basically do is now at a IMA white paper, we have decided, we have divided the illness into two parts. The first illness is a viral illness. Second is inflammatory illness. Inflammatory illness is when this is called cytokine illness. So I say there are two pathogenesis of this virus. Pathogenesis number one is viral illness part, and number two is cytokine illness. Once it releases cytokine illness, the role of virus goes away. And the cytokine illness is called as a CRP illness, and a viral illness is called as a RT-PCR illness. So if your RT-PCR is positive, it becomes negative by 9 days. Virus is gone. By that time, interferon 1 is released, and interferon releases gamma interferon, and macrophages and gamma interferon together with natural killer cells, and they take care of the virus, and the viral process is over. Now, if the cytokines are formed, these cytokines can be good cytokines and bad cytokines. Good cytokines are basically, then there are three types of responses which happens: Th1, Th2, and Th17. T means T cells, help means helper, 1 means Th1 cell, Th2 cell, and Th17 cell. So these responses will decide upon future action. If it is a good, if the good cytokines are released more than the bad cytokines, your phenomena is smaller. But if the bad cytokines predominant over the good cytokines, and the bad cytokines are, we have TNF alpha, which causes fever and tissue damage. Then we have IL-6, which increases CRP and fibrinogen, and this is IL-6. Then we have IL-1 beta, which causes fever. And then we have IL-8, which causes inflammation in the body. Now, when these cytokines predominate, then there is a predominant inflammation, and that phenomena occurs after 7 days. That is an inflammatory response. Our criteria is when the CRP starts rising, CRP will start rising between 4 to 6 hours. That's a CRP response. It will peak at 36 to 48 hours. It will peak. Then it will bring down to normal within 17 hours. So therefore, a CRP should become normal by day 4. If the CRP has not reached a baseline by day 4, it means the patient has entered into a cytokine wave. The patient has shifted from viral phase. Viral phase should be over by day 4 is when the CRP should come back to normal. If by day 4 CRP keep on rising, now we know cytokine has taken over the viral response. Then we have a formula of 10. By 10th day, the CRP should be less than 10. If your CRP is more than 10 by day 10, that means the whole body is under control of now a cytokine control. And these cytokine control can have recurrent inflammation, exacerbatory inflammation, and that can cause symptoms and cytokine crisis. If on day 10, so my options with me is I start a steroid as per protocol of the WHO or as per the recovery trial protocol. So once I start a steroid, they says give it for 10 days. Okay, I've given steroid for 10 days. My CRP has come back to normal, baseline, I stop. But if my CRP does not come back to normal, then I need to give a medicine as an anti-inflammatory medicine for the next 3 months, which is antibiotic, because I know IL-6 causes thermodysregulation, and that thermodysregulation fever is going to last for 3 months. So I need a symptomatic relief for fever, and I also need a drug which can spare the steroid. So one option is I continue steroid for 3 months. Many people are saying is continue steroid for 3 months. And second option is I give steroid with a drug which reduces fever and reduces inflammation. And third option is that I shift it to an anti-inflammatory drug and add to it colchicine, which is also anti-inflammatory. These are the options which are to be decided by the doctor. But our observation which was coming is, the observation which brought forward is that in a long COVID, it's a cytokine, persistent cytokine disease. Long COVID means after 9 days to 3 months, 9 to 90 days illness is an illness because of persistent cytokine in the body. So there are two types of illnesses between 9 days to 90 days, CRP normal, CRP more than 2. If the CRP is less than 2, they are residual damage, which is autonomic dysfunction. And if it is CRP is more than 2, we say a persistent cytokine disease lasting for 90 days. There you need a persistent anti-inflammatory drugs, mefenamic acid, steroid, hydroxychloroquine, and colchicine are the options. But when the patient is having a fever, then mefenamic acid takes over colchicine. Colchicine can be added there depending upon the CRP value. Now, these are our observations because nowadays the whole discussion is going on is a post-COVID, long COVID, long COVID, long COVID. 30 to 60% of the people after COVID, they say, we are not well. In that particular situation, divide them into two, CRP less than 2, CRP more than 2. CRP less than 2, it is a residual damage which is taking time. CRP more than 2 is a persistent cytokine, and persistent cytokines with fever, then you have to give a drug which reduces fever and inflammation. Dr. Chaudhary.
Dr. Agarwal, Dr. Mari is there, and Dr. Russell also is there from
Yes.
Australia. So, do you want to share any experience in your country, Dr. Mari? You're here, Dr. Mari?
Yes, thank you very much for asking. And nowadays, the number of patients is very few in Japan. So only in a limited clinic or hospital is seeing the COVID patients. Nowadays, I don't see any patient right now. And I'm going to
That's good.
gather information from the hospital who is taking care of the patients. Thank you very much for asking.
Oh, thank you, Dr. Mari. Dr. Russell,
Yeah,
you would like to add?
again, here they were using what KK had put, mefenamic acid was being used, but of course, right now, again, it's all we have, as you know, the number of patients, everything has come down. So, but mefenamic acid was what was being used, and also some dexamethasone. Those are the two that have been used here.
Ravi, you want to add something, Dr. Ravi?
No.
Good morning,
Dr. Ravi, welcome.
Thank you. Okay, I can't give you much information here because I'm not involved with the treatment here, because all treatment is sent to the government hospitals only. They have got designated hospitals in every place, and any COVID case has to be only sent to that hospital for further management. So we on the private sector don't have any access to this. So I'm sorry.
Thank you. Dr. Christine from Philippines, you would like to add something? Dr. Christine?
Yeah. Hi.
Yeah.
Hi. Yes, the
Hello.
presentations
Hello.
were great, and it's good to listen to all these inputs. And I believe technically we're the same in modes of treatment here in the Philippines, and basically our objective is to treat and to be of help to others who have COVID. Yes. Thank you.
Oh, thank you. Dr.
I'd
Agarwal,
like to add one point here.
Hello.
I'd like to add. Yeah.
Dr. Sharda, actually, you're just raising hand. I have seen Dr. Sharda. You're Dr. Sharda?
Dr. Sunila.
Yeah, I
Dr.
wanted
Sunila.
to say that since now, the recommendation is that all tertiary hospitals should be having post-COVID clinic also. So there we can give these guidelines from CMAAO, as well as, from IMA, that, we have to divide into 2 groups. That means CRP less than 2 and more than 2. And these guidelines should be standardized and adopted by all the clinics, because that is where you see now we are looking at in terms of post-COVID, which is now a strong recommendation that every tertiary hospital should be having a post-COVID clinic.
Thank you, Sunila. Anita, you want to add something?
Can I say something?
Yes, please, Dr. Kasir.
Dr. Kasser here. Okay. I just want to know that what about the anybody have the experience about the ibuprofen?
Yes, Dr. Kasir, Dr. Sajad, I said we did not took ibuprofen into consideration. The reason was it came into controversy in the first month, and then there were a lot of clarifications. A group said no, a group said yes. So we did not take that into our research analysis, but Pooja can add if she has done some work onto it. Pooja?
I also didn't consider ibuprofen when I was going through this. If Dr. Prabhu has...
Can I, sir?
Yes, Prabhu.
Yeah, ibuprofen and ketoprofen specifically have been shown to upregulate the ACE receptors and thereby perhaps would increase the viremic load. That was number 1 point. And number 2 point, even evidence suggests that the IL-6 decrease by ibuprofen is not as evident as compared to the other NSAIDs. These are the 2 differences, perhaps not in favor of usage of ibuprofen.
So initially, ibuprofen came into a controversy that it upregulates the viral replication. And then there were a clarification. There were 2 groups going yes and no. And because whenever there is any controversy in a CMAAO, we decided not to look into that. But yes, as on today, the current recommendation is ibuprofen is not contraindicated. And the first reaction was like an ACE inhibitor, give it or don't give it. But the current indication is that those patients who are on ibuprofen continue that. But those people who are not on ibuprofen, let the doctor decide. In the meantime, we started getting huge response with the mefenamic acid. So we started concentrating on mefenamic acid for the last 6 months.
Dr. Agrawal, I also looked at, this meta-analysis on 73 studies, which looked at, basically COVID-19, MERS, and it also looked at SARS. So primarily, this were conducted in 28 studies were in adults, 46 studies were in children, and 1 study was both in adults and children. And all studies were concerned with, acute respiratory infections or conditions which are commonly caused by respiratory virus. But none specifically addressed all these 3 issues. But then again, what was important was that all the effects of NSAIDs, they were there. They had the increased risk of ischemic and hemorrhagic stroke and MIs in adults with acute respiratory infection.
I know, Sunila, the difference is that we are talking about COVID, which is other than other respiratory diseases, because in this the predominant is inflammatory action, which is not present in others. See, the cytokine crisis is known in all respiratory, but not to this extent. So this is predominantly acute, manageable, inflammatory, immunothrombotic inflammatory viral disease. So this amount of inflammation is not seen with other viruses. Therefore, this discussion has come. So we normally say, we don't give in any respiratory disorders, we don't give NSAID because they are predominantly, it is a viral condition. There we are talking about viral replication, as there was a discussion on. Now we are looking for a drug which reduces viral replication as well as reduces inflammation. Now this virus today is so unpredictably unpredictable that we are creating literatures. This virus is creating literatures and is not behaving the way other literatures are. So I agree with you, normal respiratory conditions will increase by NSAID, but here we are talking about a phenomena which is lasting for 3 months. We have not seen any, isse pehle we used to say 1 week or 7 days. We never said 90 days. This virus is inflammatory condition is lasting for 90 days. So therefore it is not behaving like a viral phase. We are talking about an inflammatory phase. So therefore we are bringing anti-inflammatory drug. In a normal viral phase, yes, we don't have to give NSAID like ibuprofen because it can increase the virus load. Dr. Parekh.
Namaste to everyone. As Dr. Agarwal is telling, it's an purely inflammation which are going to be we are dealing with. And from day one till say 90 days, the inflammation keeps on troubling the patient. Now, mefenamic acid is a medicine which we see through the review of literature and all. It can be started from day one itself, because it is going to help in bringing down the fever as well as the inflammation. Now, beyond that, beyond anti-inflammatory action of mefenamic acid, can we think of it having any antiviral action? So the review of literature shows that along with Ribavir, it was used in chikungunya, and along with doxycycline, it was used in dengue fever. And see, they are the mainly positive sense RNA viruses. So some sort of effect of antiviral effect of mefenamic acid was considered. And in the case with doxycycline, it was even found that mefenamic acid is working in a better way as an antiviral medicine. So how does it do that? There is a process where serine protease is required for the virus to enter the cell. Now, serine protease inhibitors are the medicines which can be of use in such cases. And mefenamic acid is, we can consider it is pointing towards that it is a serine protease inhibitor. So being a protease inhibitor like Empro, this mefenamic acid can work as an antiviral in addition to its anti-inflammatory effect. So that would be making it more important in case of COVID-19. I think your comments, sir.
Dr. Parekh is an expert in this particular field, and I invited him because before I brought this feature here, I have done 7 or 8 seminars with all the experts, and Dr. Parekh gave a beautiful presentation on this subject and explained its 3 actions: antiviral, that means viral replication, and anti-inflammatory action. So what Dr. Parekh clearly says is it also has an antiviral effect. See, ivermectin, its predominant action is antiviral properties. It is not acting at inflammation. Therefore, it is an adjuvant. Alone, ivermectin will not reduce the inflammation. So ivermectin has to be combined with other things. So we are looking for, at the moment, so let me again come back to one slide. What are we looking at? So one slide I showed you to, so all of us should start looking at. See, first of all, I want to show this slide. What is our purpose? So either we kill the virus outside the body, we don't allow the virus to enter, we don't allow the fusion to take place, we kill this genome inside, we work at the level of RDRP here, or we don't allow the replication to come. So these are the avenues where we can have a virus replication. We block the virus replication process. Remdesivir acts here, favipiravir acts here, and then vitamin D acts here at the level of the membrane. So antibodies will be working at the level of receptor binding. Second option is we reduce pro-inflammatory drugs. We reduce inflammation. We increase anti-inflammatory. So IL-10, we try to find out what increases IL-10. We increase lipoxins. We increase growth factors. We reduce interferon, pro-inflammatory interferons, TNF, chemokines, IL-6. Then we can come back to, then I want to come back to these drugs. We can reduce, can we reduce IL-18? Can we reduce IL-1 beta? Can we reduce bradykinin? Can we reduce IL-8? Can we reduce TNF alpha? Can we reduce IL-6? So today, TNF alpha, we have infliximab. IL-6, we have tocilizumab. Similarly, we are looking for drugs or herbs which reduces IL-8 or IL-1 beta or IL-18. Or we can work at this level, which is the most important, is prostaglandins level. We are looking for leukotriene inhibitors here. So a lot of people are using montelukast. People are looking for PGE2 inhibitor for inflammation. So mefenamic acid comes. And then comes this is the most important. and that is this. That when it comes to cytokines, can I have block one cytokine, specific cytokine? Can I block two cytokines? So one cytokine, two cytokine, block multiple cytokines, and multiple cytokine inside the cell or outside the cell. Inside the cell are JAK-A and JAK3 inhibitors, which are inside the cell. Then this is lymphocyte trafficking inhibitor. I don't allow lymphocytes to gather. Then I say lymphocyte retention inhibitor. Then I don't allow lymphocytes to come out of the lymph node. Then I increase my good cytokines. And then I use oral therapy, which are called as small molecules for that. So what I'm trying to say is we have so many options available as on today. So we are looking for drugs which are causing fitting into this criteria. Say, for example, I take haldi. So haldi is a TNF blocker. So we have haldi is block one cytokine. Then we look for, say, we have, suppose we check ashwagandha. It blocks two or multiple cytokines at this particular level. So we are looking for combining various actions where they can work. So therefore, mefenamic acid will work at the level of virus, will reduce some cytokines, and therefore it's a good drug to combine. Now, if you are going to give only mefenamic acid, no. So we have to choose innate treatment. We don't have a standard treatment. Why not combine? So can we combine a remdesivir, which blocks RDRP? Yes. Can we combine ivermectin, which reduces replication? Yes. Can we add protease inhibitors actions? Yes. Mefenamic acid. So that's why I'm trying to find out is that we try to bring an attack at every level. So we are not using two drugs acting at the same level. That's my idea. So we are choosing drugs and treatment which acts at different levels of the viral, either at replication or at a long-term inflammation and different cytokines. So at the moment, and the slide which I showed here, is what we choose. See, this is the slide. So should I reduce IL-1 beta? Yes, because IL-1 beta causes fever. Should I write IL-6 because it causes clots? Should I use IL-18? It increases the polymorphs. Should I use tissue necrosis factor? This is the immediate response. Should I use NLRP? So the list is never ending. So this is the work which I've done in the last couple of months. Now I'm going to go detailed into more interleukins. There are interleukin 2, 3, 4, 5, 6, and to find out, even I'm combining it now data on herbs, which herbs reduces, which are equivalent to mefenamic acid, ivermectin, doxycycline. That's the second part of my study which I am working. But at this moment, I am working on, tell me which drugs, which cytokine you are reducing. Because we are not talking about fever, we are talking about cytokine. If they, say, for example, if you say, I'm working at IL-1 beta, then it should be able to give you a fever drug. So those herbs which reduces IL-1 beta should be used as an antibiotic. Any drug today, when we're looking for an off-label use of a drug, any drug which says I reduce IL-1 beta, so I can come back and say it has to reduce fever because IL-1 beta is the one which causes fever. That's how I'm working on it. See, we have never worked with this mind in our life. I have never worked in this life. We were taught fever means paracetamol, respiratory means bronchodilator. We have never gone into the level of cellular biology. Now we are working on a cellular biology. Tell me which IL-6, which TNF, which cell, NK cell, which cell you are talking, how to increase, how to reduce. Because this virus is teaching us a different type of a medicine. Dr. Parikh.
Exactly, sir. And that's why we are looking into the minor aspects of this disease. So like we talk about NLRP. Mefenamic acid is a very good medicine. It is an inhibitor there, and the action, anti-inflammatory action, starts from that place. And beyond that, beyond anti-inflammatory, the other effects of mefenamic acid as an antiviral, that becomes more important when we are considering the disease as a whole, and which medicine can be started from the very beginning, very day one of illness, that is mefenamic acid. The anti-inflammatory action of the medicine is there. And when are we going to add steroids? Do we add steroids from the very beginning? No, we are going to add steroids after say 4-5 days of the illness. So initially, steroids may cause harm to the patient. So at that level also, mefenamic acid is going to work well in those patients as an anti-inflammatory, as an antipyretic. So to the cellular level, biological level, you have to consider the role of this particular medicines or any other medicine which we are going to prescribe in say COVID-19, along with some of the things you mentioned like haldi and all those things. They have got very good anti-inflammatory and antioxidant effects. So a combination of all these medicines are to be used. We just cannot depend on one particular things, and still we are not very clear. Maybe some medicines have been now FDA approved, but there have been certain controversies. So we have to see which is a general medicine, which is not to be rediscovered. It is just repurposing. So repurposing these medicines would be good.
So I'll like Dr. Jamal to close this part of the discussion. Then all our guests can go. We'll continue our CMAAO meeting. With this, our special guest for this meeting can leave after.
Just before that, can I, Dr. Agrawal?
Yes.
Can I just ask you observation regarding the WHO has already indicated that no drug is just appropriate or proven positive for COVID on the this trial they have conducted. But I have seen the US FDA already they have recommended that the remdesivir. Yes.
So we will discuss. Chaudhary, I want you to finish because we are continuing our CMAAO meeting. So all our guests who have been specifically called for the anti-inflammatory action. So you can summarize that, then they can leave. We will continue our meeting for another 15 minutes. There we will discuss that.
Okay, thank you so much, Dr. Agarwal. Actually, this is a very nice presentation you have given, and really we're benefited everybody with this presentation. And thank you, everybody. Thank you, all participants.
All our guests, special guests, they can leave. Yeah. They can leave. We will continue with our internal CMAAO meeting. So Pooja, you can request all the people who have been invited, they can leave. That meeting, which belongs to anti-inflammatory action, where we have called some experts, that meeting is over. So now we come back to Dr. Jamaluddin Chaudhary's question. And Dr. Parikh and Dr. Ketan Mehta, you can stay because this can be of interest to you. And what we are basically talking about is one day, this is a confusion. And I think a statement should come from CMAAO. This is the confusion. WHO says no, US says yes. India says no, one of the government says yes. So this is happening too much. And people are confused. Yes. And our statement should be, leave it on the treating doctor. Let the treating doctor decide, because in this condition, the literature is created and not to be seen. So create the literature at this particular moment, because what may be eligible today, tomorrow it may not be eligible with that. So therefore my answer is very clear that we can't go by, because once the US FDA says approved, WHO says no, my answer will be, let it be the professional autonomy of a doctor to decide on a case-to-case basis, because literature is bound with a lot of limitations. Literature statistics is bound with a lot of limitations. It is a personal experience of a doctor who will decide what works best for what particular patient in that country, in that age group. That's my answer to that. Dr. Mehta, you want to say something to this? Ketan Mehta, on this issue?
Yes, sir. I would strongly agree with Dr. Agrawal, sir, because we have seen personally the experience with remdesivir, especially with the severe infection, who have got a lung involvement, high oxygen requirement, the response is very good. So whatever may be, it may not benefit in terms of mortality, but it definitely reduces the severity. And we would strongly agree with Agrawal, sir, that probably we need to the personal decision of the treating physician, but we are definitely seeing response in severe cases where the viremic load definitely comes down faster. So I would go for it. Thank you.
But can I just see actually after the WHO's this comment, and then only the manufacturing company actually they have just opposed first from the USA, and then we have seen the reaction from the US FDA. I don't know what is the link between that, and
No,
actually whether we have. Yeah, please,
Go ahead.
Dr. Gawar.
Go ahead.
No, I just want to say, ask you that whether any sort of study has been done in India, because India is having a lot of patients now, and so have you gone through this any sort of study regarding the remdesivir as well as ivermectin? Also, you are saying all the, but in Bangladesh actually there is studies going on, but we have not got any sort of result from it.
Regarding ivermectin, 2 of the states have put ivermectin into their state protocol. That means it has become in the list of essential medicines. So the largest state of India is Uttar Pradesh. They have put it as a prevention and treatment protocol. And then one northeast state has also put it into a part of their protocol. In fact, 3 states have put it as a part of their protocol. There are more than 12 trials going on in India regarding ivermectin. Now, ivermectin will stay as a off-label use. Ivermectin, Dr. Chong also has joined. Now, ivermectin, advantage of ivermectin is it is an anti-helminthic. Okay. India also has a program for filariasis. India has also a program where anti-filarial treatment, they are talking about carbamazepine along with ivermectin. They are talking about it. So ivermectin is a separate issue altogether. But when it comes to remdesivir, it is used outright in India in every hospitalized patient. They are using it, but as on today, the data only DCGI will decide, because it is once the US FDA has allowed, then automatically DCGI will take it up and decide whether they take it as a standard drug in India or not. Till that, it is emergency use authorization.
Thank you. Thank you. Dr. Chong has joined. So
Dr. Chong also has joined.
Chong, and Dr. Alvin also has joined.
Yes.
Absent, Dr. Alvin.
The chair, up till now, the chair was Dr. Chaudhary, and he was waiting for you. And the question now comes is remdesivir. We have discussed today a presentation on anti-inflammatory action. And now the question is remdesivir withdrawal, where do we go? WHO says no, US FDA say yes. So what should be the reactions of CMAAO in such a situation when 2 conflicting results comes? So I made a statement is professional autonomy. Let the treating doctor decide what is best for that particular patient. Dr. Chong.
Sorry, I was late, President. I was treating my brother who fell and had a big gash on his head. CT scan him, he's okay.
Oh, good.
So sorry about that.
Any housefly which died? Any ant or a housefly which died?
Sorry?
Whenever there is an injury, so if the person is all right, then we start looking for did any ant or a housefly died?
That's a good one, President. So yeah, this remdesivir, I think professional autonomy is correct, President. One more thing, President, you recall a couple of meetings ago, you had a long talk with us about the different markers during COVID that presented. Remember the ILs, the interleukins, and the CRPs and all that. Do you recall? You had a whole, you gave us a whole spiel of everything.
That was I spoke today. You were absent.
Could you summarize it for us? It was very, very useful to have all that in let's say an email.
When the virus enters my body, okay, and it is attacked by the mucosal barriers, and that mucosal barriers are taken care of by the zinc. If my mucosal barriers are not there, virus enters inside. At the level of virus entry, ivermectin, mefenamic acid, and the vitamin D can act. Then my virus enters in my body through RBM, which is receptor binding domain. And then there is a membrane binding domain. In between the two, there is an action of a cilial protease. And that protease, if you inhibit, virus will not enter inside. And there comes the role of mefenamic acid. Now, when the virus enters my cell, it is taken off by ORF1A and ORF1B, which is the top portion of the spike protein. They releases the RNA genome, and that RNA genome is released by an enzyme called RDRP. So if I block RDRP by remdesivir, or if I block RDRP by favipiravir, then my replication will not occur. Then this virus starts replicating in my body. This is one aspect of replication. Then this replication process is also inhibited by ivermectin. Now, once my virus cell is infected, now it is an infected cell, it starts producing its material. Okay. Now, like a factory of a garment, when you go to a garment shop, outside you have the design. Outside you have the design, what the factory is making. So an inspector comes and he finds out, yes, there is a design of that made which is manufactured inside. This is called histocompatibility. The name is called as, let me just see, 1 second. I shouldn't be making a mistake. Now this is called as class 1 major histocompatibility complex protein, which is called as MHC class 1. Okay. Now this protein is present on every cell on the top. So from distance, the cytotoxic cells, they recognize in the cell what protein is being manufactured. Now, if they start manufacturing viral protein, that protein trace will come on the surface, and the T cell will say this cell is infected and it will kill that particular cell. So these are called T helper cytotoxic T cells, which are C8 cells. So there are two types of CD4 and CD8. The CD8 cells, which are cytotoxic T cells, will start killing it. Now, virus is very cunning. So it will, what it will do is, it will make protein in the top so low that nobody recognizes what type of a dress is going on. Then natural killer cells comes, whose job is to recognize very small amount of protein or a cellular cell and talk about this cell has been hijacked by a protein. So natural killer cells will start killing it. Now, both these cells, natural killer cells and the cytotoxic 8, that is CD8, helped by CD4, helped by macrophages, they start producing, killing the cells. Now, when they kill the cell, when they kill the infected cell, the first thing which is released is interferon, which is 1A. Now, interferon job is to kill the virus, the cell, as well as to communicate to other cells that virus has entered. So the first is interferon 1A. And now WHO says interferon 1A therapy has not been found to be useful, because that's what the solidarity trial used, interferon 1A. So if you use interferon, gives the message to other cytotoxic cells, which are called as NK cells and CD8 cells. Now, when this cells, the infected cells now has to be killed. Now, how will it be killed? When the infected cells enter the pneumocyte 2 of my body, which is in the lungs, the first cytokine it produces is tumor necrosis factor alpha, TNF alpha. Now, it is something like that Dr. Chong's, that Dr. K.K. Agarwal's home has been raided by thieves. So there are some terrorists who have entered my house. So my wife, my children at house with my local security will produce TNF alpha, will try to manage that. So TNF alpha through PLA2, phospholipase A2, will produce, they will start fighting with the thief and try to control. So there will be local inflammation, local damage. Local damage will cause some rise in ESR. There will be some release of ferritin. There may be some release of C-reactive protein and IL-6. Now, if my wife has not been able to control, she will tell my son, call Dr. Agarwal. Now, this is called messenger, and that job is done by the interferon. And that is called messenger cells. These are called, now the message goes to Dr. K.K. Agarwal. Then I start calling the police, I start calling others. Now this becomes from local to systemic manifestation, systemic reaction. And systemic reaction is interleukins. So from local, which is tumor necrosis factor, the response has gone to a systemic reaction. Now, once there is a systemic reaction, body shifts into a systemic inflammation from a local inflammation. Now, this systemic inflammation occurs at 5 places: skin, liver, gallbladder, blood. That is second. Third is esophagus, stomach, and small intestine as the third. Fourth is the heart. Fifth is the eyes. These are the 5 locations where interleukins are present, from where the messages will go to the whole body and the fight will start. This is called as an interleukin response, which is humoral response. And these interleukins are multiple interleukins, which can be interleukin 1, 2, 3, 4, 5, 6. Now we have good interleukins and bad interleukins. The good interleukins are called IL-10. IL-10 is a good interleukin, and rest of them are bad interleukins. Now, when we talk about the bad interleukins, the predominant one of them are, let me just go back to that slide. I want to show you this. I want to show all of you that slide, which you should copy. So this is the slide which I want you to see. 2 slides I want you to see. This is the slide that is interleukin 6, TNF alpha, interleukin 8, interleukin 1 beta, and interleukin 18. There are many responses which comes, but I have predominantly one. IL-18 will directly cause inflammation. IL-1 beta will be responsible for gel formation in the lung. IL-1 beta will be responsible for high ferritin levels. Bradykinin will be responsible for increased vascular permeability and endothelial dysfunction. IL-8 will be responsible for neutrophilic migration in that particular area. TNF alpha will be directly related through phospholipase to PLA2 to inflammation. IL-6 will cause increased CRP and increased fibrinogen. Increased fibrinogen will cause to D-dimer. Now, these are the cells. Now, here there are, now what is being produced by the Th1 cells? Now, their Th is called T for, this is called thymus, H for helper. So Th is a CD count. These are CD cells. So TH1, 2, 3, 4, 5, 6, 17. Normally, the responses are TH1, TH2, and TH17 response, which causes various types of interleukins. If you read, you will find there are multiple interleukins having their action. I've already only picked up 5 of them at the moment because they are directly related with various types of manifestations which can be explained. So IL-16 will explain rise in D dimer. IL-1 beta will explain rise in ferritin. With that, that IL-1B will explain to you IL-8 will increase this neutrophilic migration in a local area. This is what I basically try. Now these inflammation should vanish. So the criteria clinical is C-reactive protein. That's our clinical criteria. Out of this, when we measure C-reactive protein. And we say that CRP will start, when virus enters my body, CRP should start rising within 4 to 6 hours. So within 4 to 6 hours, CRP should rising. It should start multiplying, become doubling every 8 hours. By 36 to 48 hours, it should reach peak. And when the stimulus virus is killed, it should come back to normal within 17 hours. Therefore, by day 4, your CRP should be back to baseline. If your CRP is not back to baseline by day 4, it means your cytokine response is still persisting in the body. And if the cytokine response is still persisting in the body, then we start looking for CRP doubling rate, and we start looking for CRP ratio. CRP ratio is today CRP decided by CRP on day 0. And then we start looking for a rising CRP ratio, and we start looking for a doubling CRP after 4 days, means cytokine response. Now, acute rapid rise in CRP means IL-6 is rising. If IL-6 is rising, we know IL-1 beta is also rising because patient has a fever of more than 101. And this is how we decide in the management. Though we can measure any other, we can measure TNF alpha, we can measure IL-88, we can measure interleukin 1 beta, but clinical criteria we use is interleukin 6. Dr. Chow.
Dr. Agawa, may I ask you what is in the slide CSS and CDC?
CDC is cellular dendritic cells, and CSS is the cytokine syndrome.
Cytokine storm syndrome? Thank you. Thank you. In fact, I think the slides are very helpful. I just wonder if you could also show us the slides in an email, because just now there are so many very rich contents in the slides that we could not really follow just in 1 minute. Thank you.
Thank you, President. Excellent. I listened to you and quickly took all the notes as fast as I could. Thank you. Very excellent tutorial.
I'll do one thing is next week, let me again do the same class. I'll go very slow and we'll go further deep into it. So all of us now becomes, so we start talking to the mini Chong within Chong. You have 6 million milli Chong sitting inside Chong, Dr. Chong. So we'll start talking to that level of a mini Dr. Chong sitting within Dr. Chong. So that means cellular level. So we will debate, the next time will be a cellular inflammation. We'll talk only about a cell, not the human body.
Thank you, Dr. Agawa. Thank you, President. Always very enlightening listening to your seminars and to our seminar, and always such a collegial experience. So I think, sorry I've joined you so late, but what a important 5-10 minutes that was just now. So without much further ado, I think we can call a close to today's meeting.
No. Sorry.
We have to talk
we have still many things to talk.
Oh, is it?
We had not started the meeting, I think.
Okay.
No.
We had just finished a lecture, but then we had not started the meeting.
Oops. Please carry on.
Yeah.
Dr. Chaudhary, please carry on.
Yeah, because
WMA meeting.
Yeah, because the president had asked us to have some CMAAO presence in the WMA meeting a few days later. I think we have to have some arrangement about that. And especially, may I just draw your attention that in fact, in the report of the WMA, there are 2 paragraphs about Hong Kong. First of all, they had mentioned about the breakdown of the medical service in Hong Kong during the protest or the riot in Hong Kong. And some of the council members of the Hong Kong Medical Association didn't agree with that statement, in fact. And the complicating factor is that the Chinese Medical Association is also not contented with such a description. And so, of course, that's not discussed in CMAAO, but it concerned Hong Kong, then it also concerns CMAAO. This is the first thing. The second thing is, I think we have to talk about Korea, because, well, although we didn't have their participation so far, but in Hong Kong, that kicked up a mess in Hong Kong as well because of the mortality of almost 50 vaccinees had died after vaccination, although the government said it's not related to the vaccines directly. But in Hong Kong, it served to kick up a little panic in the doctors, afraid that if there's something happen, is it defendable when we are giving Sanofi vaccine? And of course, I don't agree at all to have anything panicky among the doctors, because it's already declared by Sanofi that it's not related directly to the vaccine. And also because 5 million vaccines in Korea have been misplaced in room temperature. And that's why it had shaken the confidence of the people in Korea. So many people from Korean Medical Association had advised the government to halt, to stop for a while their free vaccination program. But then the government denied there's any relation. So I think in Hong Kong, the doctors also had some worry. So I just wonder whether there are any problems encountered in Singapore, Malaysia, India, or Bangladesh, or other places, Japan. We just have to be alert and get prepared when the public really queried and our members queried. And of course, we are all waiting for the autopsy reports in Korea. So then they could give us the reassurance that it is definitely not related to the vaccines. So I don't know whether, say, Dr. Chong and Dr. Aguawa, do you have any, and Dr. Jamal, do you have any insight into that situation in Korea? I think it's quite an urgent matter that Hong Kong, among the medical doctors, we are asking. Thank you.
Yeah. Thank you. Can I just add another one? I've gone through the WMO statements coming up about the what I have seen only in Uyghur is in China. They are talking about the inhabitants of Uyghur. They are compelled to go for the production of PPE mandatory, and something like that. They are forcing them. So WMA, this is actually initiated by the British Medical Association, and the WMA wants to give a statement regarding that is human rights violation regarding this. Yeah. So this is also raised, and I don't know whether you have noticed it or not. Dr. Chong? Hello?
Yes.
Huh.
In Singapore, we don't have much of a, so far there hasn't been much of a reaction on this Korean episode. We are watching the situation closely, apparently, according to my friends in the ministry. But so far, there's been no major reaction in Singapore over the safety of the flu vaccines. I mean, so far it seems to be all right. We're
Yeah,
watching
good.
the situation very closely. So I don't know, were all the vaccines in Korea, I mean, I don't have enough information, were all the vaccines in Korea local vaccines, or because I saw the news report, it was a locally made vaccine, or was it Sanofi?
The majority were locally made Korean vaccines, but 5 or 4 people had died. They had received Sanofi vaccine. And of course, in Hong Kong, about, I think, at least 1/3 of the vaccines were provided by Sanofi, and then another third by GSK, and then the rest by AstraZeneca or Abbott and others. We didn't import Chinese or Korean vaccines. But then at least 4 had died after Sanofi vaccination. And that's why in Hong Kong, the doctors also queried. And the mass media, of course. The most important thing is the mass media.
Yeah, definitely. So.
Yeah. Any idea what's the denominator in Korea on the number of people vaccinated versus the number of deaths? Is there a denominator? Any idea?
They will in total vaccinate 30 million citizens out of the 52 million. Then now it's only mid-October or late October. I guess they were just started vaccinating not for a very long time. In Hong Kong, we just started vaccination since the 8th of October, only for now 2 weeks. I guess similarly in Korea. But then it would be a big confidence crisis in the vaccination, because all along, Korea has been a successful model of good vaccination coverage. They had been boasting 60% or even above of vaccination coverage, even better than the USA, you know. In Hong Kong, we all along only achieved about 20% or something like that. So it would be a big confidence crisis if Korea failed. So I think that is very important. It's also a big challenge from the anti-vaccine naturalists, you know. So in America and also in Hong Kong. And so I think this is a very important battle in the vaccination field, I think.
But do you have any idea about information about the pausing of this trial? Phase 3 is going on, is it?
Oh, you mean COVID vaccine? Yeah. No. Well, for the Chinese, they always said it's 100% success.
I'd like to intervene, Dr. Chaudhary. I'd like you to sum up because I have 11 o'clock in back-to-back meeting.
Yeah.
I will request Dr. Chong because I will be present in WMA as a CMAAO observer. So I may not be allowed to vote or to even present. That will be represented by Indian Medical Association. So my purpose of ending up today is Dr. Chong, before the WMA, if he can organize a meeting of CMAAO countries, whosoever wants to come, then all of you can discuss your issues where you need each other's supports when it comes to WMA. So if suppose Bangladesh has an issue, then that should be that can become supported by CMAAO countries. So the whole idea is that if Dr. Chong can coordinate with me, come out with a 1-hour meeting for those interested people who wants to raise some issue where you can build up a consensus that each of one of you can support each other. That was
all right.
So we can do it, say Monday or Tuesday at a time convenient. That Dr. Chong, Saurabh can discuss with Dr. Chong and fix up a meeting where so we can have we can meet it day after tomorrow, same 9:30 for 1 hour. Same time on Monday, Dr. Saurabh can call everybody, and whosoever is present, whether 5 countries, 6 countries, 7 countries, if they are raising some issue. So if they are raising some issue, they can put down their presentation. This is what I'm going to raise. This is what support you want. And if everybody agrees, then everybody supports that. That's my idea of discussing this issue.
Can you just call a meeting, actually formal meeting in the this WMA GM meeting in between formal CMAAO?
That I've already asked Dr. Chong to organize, if it is possible to organize a WMA, during WMA, ask the WMA to organize, give us a half-an-hour slot where all the countries can, where we can call WMA President, Secretary General to participate as an official, which you officially chaired that meeting, and where we discuss CMAAO issues.
Okay.
That has to be done by the chair or by the secretary, because I requested, I've written to the secretary also, but then Chong can do that. There's still time. And,
Okay.
And if it, even if their platform doesn't allow, we can do it in our platform and invite the WMA president
Yes.
and secretary to be present.
Okay.
So, Dr. Chong, you are also a delegate from Singapore, right?
Yes.
Thank you.
Yes, I am.
So
Thank
let's
That will be
have,
great.
Chong, can you finish it up? Because I have another back-to-back meeting.
Okay. Thank you, President, always for that very informative little tutorial on that I've taken notes on the inflammation response in the COVID infection. Much appreciated. And thank you everyone for their attendance today. Apologies for being slightly late because of a family emergency. But otherwise, happy to see all of you. Maybe on Tuesday, I'll arrange with Sarab for those who are keen to join us to discuss on matters arising about WMA. Otherwise, we'll all see each other next Saturday as per normal, our usual time. Thank you all.
Okay, thank you.
Thank you so much.
Thank you very
Thanks.
much. So we meet on Tuesday.
Thank you very
thank you.
much.
बंद करके restart कर दो.
Thank you.
Thank you.
Thank you. Thank you.
पूजा.
Hello? Okay, आवाज नहीं आ रही.